Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas, who has been in practice for more than 40 years. The feature presentation is over-treating blood pressure bad? And if so, why? So let us explore this phenomenon. So let us begin with the feature presentation. According to the American College of Cardiology and the American Heart Association, here is a chart showing the various systolic and diastolic blood pressures and their significance. The normal systolic blood pressure is supposed to be less than 120 and the diastolic less than 180. By the time you reach blood pressure 130 to 139, over 80 to 89, you are already considered to have mild hypertension or stage 1 hypertension. And if the blood pressure is between 140 or higher and the diastolic 90 or higher, you are supposed to be in hypertension stage 2. So that is a significant jump. And of course, anything over 180 systolic is considered hypertensive crisis. That may be associated with headaches, blurred vision, dizziness, or even weakness, and a diastolic over 120. So keep these numbers in mind. There has been a significant push towards bringing the systolic and diastolic blood pressure in every age group, regardless of their cardiovascular condition, status, or risk factors. And this over tendency to bring the blood pressure down has found to be sometimes beneficial and sometimes harmful to the population, especially in the ages 60, 70, or 80s. And we're going to look into that data in a minute. As I said, there are three different stages of hypertension, namely stage 1, stage 2, and hypertensive crisis. However, the classification gets a little bit muddy when you look at the criteria used by the American College of Cardiology, the American Heart Association versus the JNC 7. Here, what is considered as 140 over 90 to 99 as a stage 1, the ACC considers it as already stage 2. But nonetheless, the numbers are arbitrary, but we do need to stay within the ranges for achieving the maximum benefit of treating hypertension in terms of reducing cardiovascular problems and also in terms of reducing stroke. There is no question adequate treatment of hypertension can result in 60% reduction in the stroke incidence. That is not so much so when it comes to cardiovascular disease risk reduction. The cardiovascular disease risk reduction amounts to about 15 to 20%, but as we continue to bring the blood pressure down, it may have a negative effect on the benefits of cardiovascular symptoms or disease progression. So let us look into that data. As we can see, most of the blood pressure charts talk about age up to 60 to 64, the maximum being systolic 147 over 91. However, there are no numbers. I looked all over recommended by the ACC or the American Heart Association or JNC as far as what is an acceptable blood pressure for people between 65 to 70, 70 to 75, 75 to 80, and 80 plus. The important thing we need to keep in mind is as we get older, our blood vessels become stiffer. There's more atherosclerosis. There's more hardening of the arteries, and that has a profound effect on how well our blood pressure responds to medications or even just standing up from a sitting position. And here is a further explanation of what I was talking about. As we get older, our arterial walls develop these atherosclerotic plaques. Our arterial walls develop atherosclerotic plaques. There's deposition of all this cholesterol in the arterial wall, which leads to stiffening of the pipe. Think about it as like a flexible rubber pipe, but when it becomes like more like a stiff rubber pipe or like a plastic pipe, it has no distensibility. It loses its elasticity. As a result, in the elderly population, the blood pressure response is quite brisk from one extreme to the other. In other words, if you give medications to bring the systolic blood pressure down, it can bring down the blood pressure quite precipitously, because when you stand up, these blood vessels don't respond in a normal fashion that you would expect, like in an adult person with pliable or flexible blood vessels. So, in summary, in the elderly population, the arterial walls are stiff, there is fixed peripheral vascular resistance. These vessels are non compliant, so they have a tendency to have severe systolic hypertension, especially in the age group 75, 80, 85, 90, and they experience significant postural hypotension with aggressive treatment of hypertension. So here are some of the studies which looked at lowering the blood pressure in the population, and they found out that as we lower the systolic blood pressure, the risk gets better, but when we go below 120, actually the risk goes up. So this is like a U-shaped curve, and it is the same thing with the mean arterial pressure. And that is with the systolic. And here's another study, 4 different studies which show a bell-shaped curve here. As the blood pressure is extremely high, the risk increases up to a certain point, like up to 130. And beyond that, if you were to further reduce the blood pressure, the incidence of cardiovascular diseases go up significantly. So keep that in mind. Being very aggressive in trying to reduce blood pressure could be counterproductive to what you're trying to achieve in terms of reducing cardiovascular risks or stroke manifestations. At the same time, we have to keep in mind that reduction of blood pressure is important, especially if the blood pressure is running 160, 180. But in the elderly population, we have to monitor their blood pressure when they come in, 5-10 minutes later, when they sit up, and when they stand up. And you have to match all those numbers to see what is the optimal blood pressure you can achieve. It is not what is the minimum blood pressure that you can achieve. It is what is the optimal blood pressure that you can achieve without any cardiovascular symptoms like dizziness, weakness, or collapse. So, ladies and gentlemen, here's that another study which looked at like 1,126 patients, 88 years old. This is the elderly population. There was a 2-year follow-up. As you can see, 22% died, which is 10% mortality for a 80 plus population, which is expected. But what is more interesting is those people who had a systolic blood pressure less than 130 had a much higher morbidity and mortality compared to those people who had a blood pressure 140 to 201. So drastically trying to reduce blood pressure in the elderly population can be counterproductive, and it can be detrimental to the patients. So, ladies and gentlemen, here's the same study. You're looking at the diastolic blood pressure. When the diastolic blood pressure was between 106, between 76 and 107, they had the best prognosis compared to those people whom we are trying to reduce the blood pressure below 70. And that's an important number to keep in mind, especially in the elderly population. So the best way to do this would be to do a 24-hour blood pressure monitoring, which can monitor their blood pressure under various conditions, lying, sitting, during activities, and during sleeping. So we can record all the activities. We can see the response to medications. We can also monitor their pulse, because atrial fibrillation can have a profound effect on how the blood pressure is recorded on these machines. We can look at the circadian cycles of changes in the blood pressures and see what's best way to monitor the blood pressure without increasing their cardiovascular risks or without increasing their symptoms related to the drugs. So, ladies and gentlemen, this is a quick review of what can happen when you bring the blood pressure down dramatically. In fact, in patients with multiple risk factors like obesity, diabetes, hypertension, you do want to bring the blood pressure down. And an important thing to keep in mind is as you reduce the carbohydrate intake in diabetics, the blood pressure level comes down automatically. As you can see, the systolic blood pressure dropped from 143 to 132, and the diastolic dropped by about 6 points. So these are some of the things we need to keep in mind when we are managing patients with hypertension, especially in the elderly population, because the goal is to minimize the cardiovascular risk and also to minimize any side effects related to the drugs in terms of weakness, dizziness, or even collapse. Thank you so much for watching this presentation. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. And please do subscribe to our YouTube channel, and I will see you in the next presentation.